Radical Mastoidectomy by P.L. Dhingra, Chapter 81. Radical mastoidectomy is a procedure to eradicate disease from the middle ear and mastoid without any attempt to reconstruct hearing. Posterior meatal wall is removed and the entire area of middle ear, antrum, attic, and mastoid is converted into a single cavity. All remnants of tympanic membrane, ossicles, except stapes footplate and mucoperiosteal lining are removed. Eustachian tube is obliterated by a piece of muscle or cartilage. Aim of the operation is to permanently exteriorize the disease area for inspection and cleaning. The radical mastoidectomy is infrequently required these days. Indications 1. When all colostoma cannot be safely removed, example that invading the eustachian tube, round window niche, perilabyrinthine, or hypotympanic cells. 2. If previous attempts to eradicate chronic inflammatory disease or colostoma have failed. 3. As an approach to petrous apex. 4. Removal of glomus tumor. 5. Carcinoma middle ear. Radical mastoidectomy followed by radiotherapy is an alternative to en bloc removal of temporal bone in carcinoma middle ear. Anesthesia. Mostly general anesthesia is given. Local anesthesia can be used in selected cases. Position same as for cortical mastoidectomy. Sites of operation 1. Incision, postoral or endoral incision. 2. Retraction of soft tissues and exposure of mastoid area. Mastoid area from posterior root of zygoma to behind the suprameatal triangle and from temporal line above to the lower part of the mastoid tip below is exposed by elevating the periosteum and wound retracted. 3. Removal of bone and exposure of attic and antrum. With the help of burr, bone is removed from the area of suprameatal triangle, spine of Henle, root of zygoma to just above the anterior meatal wall. Upper part of the superior meatal wall is also removed. This will expose attic and antrum, identify the tegmen antri and lateral semicircular canal. 4. Removal of the bridge and the buttress. Deeper or part of the superior osseous meatal wall that bridges over the notch of Ravenous is removed. Anterior spine of the notch, anterior buttress, and the posterior spine of the notch, posterior buttress are also removed. This removes the lateral attic wall. The incus and the malleus are also removed. 5. Lowering of the facial ridge. The deeper part of the posterior meatal wall that overlies the vertical part of the facial nerve is also called facial ridge. It is removed as much as possible within the safety of seventh nerve so that the mastoid cavity is freely accessible from the meatus. 6. Toilet of middle ear. Remnants of tympanic membrane with its annulus and sulcus tympanicus are removed. Middle ear mucoperiosteum along with any polyp or granulation tissue is removed. Malleus and incus are removed if not already done. Stapes is left intact. Eustachian tube opening is closed by curating its mucosa and plugging the opening with tensor tympani muscle or piece of cartilage. 7. Inspection of cavity and irrigation. It is necessary to ensure complete exteriorization of the attic, antrum, and middle ear and mastoid cavity into external auditory meatus. Any bony overhangs are removed and cavity smoothened with polishing burr. Finally, it is irrigated with saline to remove any blood or bone particles. Meatoplasty. A flap based laterally at the concha is raised from posterior and superior meatal wall and turned into the mastoid cavity to cover the area of the facial ridge. This helps in the epithelialization of the mastoid cavity. A piece of conical cartilage can be removed to enlarge the meatus and to facilitate inspection and access to cavity. 9. Obliteration of the cavity. If mastoid cavity is very large, it may be obliterated with temporalis muscle or other soft tissues. Taking care, no vestige of disease cholesteatoma is buried underneath. Figure 81.1 Radical mastoidectomy. The entire area of mastoid, middle ear, attic, and antrum is exteriorized. Eustachian tube is obliterated and no attempt is made to reconstruct the hearing mechanism. Mastoid cavity, facial nerve, seventh nerve, facial ridge, round window, Eustachian tube opening, closed with muscle. Stapes. Figure 81.2 Types of post-oral incisions: anterior, up, down, and posterior. A, B, C. 10. Closure of the wound. The cavity is packed with ribbon gauze impregnated with an antibiotic or antiseptic, and the wound is closed with interrupted sutures. Master dressing is applied. Post operative care 1. Dressing. First dressing is done on the third or fourth day. Replace the outer gauze and cotton and look for any signs of perichondritis or infection of meatal pack. Figure 81.3 Endoral incision. Second, dressing is done on the sixth or seventh day when stitches are removed and meatal pack is changed. Thereafter, change the pack at weekly intervals and leave the cavity unpacked with regular suction and cleaning till epithelialization is complete. 2. Antibiotics. A suitable antibiotic is given for about a week. 3. Cavity care. Usually, cavity is fully epithelialization in 2 to 3 months. It should be periodically checked every 4 to 6 months in the first year and then annually for removal of any debris or infection. Any granulation tissue which delays epithelialization is removed or cauterized. Complications: 1. Facial paralysis, 2. Perichondritis of pinna, 3. Injury to dura or sigmoid sinus, 4. Labyrinthitis if stapes gets dislocated, 5. Severe conductive deafness of 50 decibel or more. This is due to removal of all ossicles and tympanic membrane. 6. Cavity problems. 25% of the cavity do not heal and continue to discharge, requiring regular aftercare. Thank you.